and sir will be talking about quality improvements in neonatology.
So good morning to all of you. First of all, let me thank Dr. Arun Kumar Sharma. I saw Dr. Krishna Kumar also sitting in the audience, Dr. Rajesh and the organizing committee, to give me the opportunity of coming to Ranchi once again and to share with you something which is going to be the main area in which healthcare will have to focus for next 2 decades, and that is quality improvement in healthcare, and especially for neonatology. And to me, working at IXth has educated me that it is not only clinical care, education of resident doctors and fellows, and doing clinical research which matters. There is a fourth pillar which is so important, which is quality improvement for healthcare. In any specialty you work, and for the last 2 years, I am privileged, and I would say that my director, who is a trauma surgeon, Professor M.C. Mishra, he shouldered a responsibility on me to make sure how quality improvement can happen, not only in pediatrics and newborn, but in all specialties in All India Institute of Medical Sciences, New Delhi. And for doing this task, what we are lucky is that the younger faculty members and younger healthcare providers who are not so old readily join this effort of quality improvement. And at this outset, I would say, keep in mind, quality improvement is in the hands of healthcare providers, the frontline workers, the doctors, the nurses, the class 4 employees, and the families, because it also encompasses the experience of care by the family and the satisfaction by which they go home. We have a website which is www.aiimsqi.org. If you want to look at what we are doing in the whole CRO region and at All India Institute of Medical Sciences, and how we are growing and making a network of quality improvement by doing capacity building of individuals, please log on to this website. I wish at the end of next 20-25 minutes that I would be able to convince you that you should try to solve problems which occur at galore in the NICUs and in pediatrics care. You don't have to, if you don't look for them, you will never come to know what these problems are. But if you look for them, you will find large number of problems which are there. And the dictum here is, these problems have to be solved not by you alone. It has to be solved by the team of individuals who have decided a common aim that they want to fix that problem by fixing the processes of care. And we learn all this, which is coming from the industries, how processes of care improve the quality of products for the consumer and how the consumer drives the economy in the industries. I was so happy listening to Dr. Naran yesterday and few of the talks which people have given. And let me just put a question to you, that how many of you who are sitting in this room collect your neonatal perinatal database and data variables, and how many of you look at those variables? There are few people who are raising hands. It means the first thing which has to happen for doing quality improvement is the data collection. Without measurement, you will not be able to do any quality improvement project which you want to do. And what I am going to share with you, that it is not only a complex thing which you have to sort out while you want to do quality improvement. Always start with simple, feasible projects, learning the basic tools of quality improvement, and then trying to fix up complex problems which are there in the NICU. I saw there in the paper, which is from the Bluebird, which says there are nearly more than 40% of babies in the SNCUs which are getting admitted hypothermic. We need to find out what is the process of care where these babies are getting hypothermic, and trying to do a change by a team of people, and then keep on measuring whether you are able to reduce that incidence from 40% to anything which is 10% or 20% over a period of 6 weeks. So you need to think that way. The last presentation was that cesarean section leads to more of late preterms, more of morbidity in the babies. If your facility has cesarean rates which are so high, 40%, 50%, can you reduce that to 20%? Or World Health Organization says for normal deliveries to take place, the rates of cesarean should be only 12 to 15%. We don't realize by doing cesarean what harm we are doing to the mother. We don't realize what harm we are doing to the babies who are born by cesarean section, which was shown by previous presentation. Babies don't develop immunity properly. Mothers have placenta accreta, placenta previa the next time. And look at how many days she will stay in the hospital following the cesarean section. The rates of depression and psychological disorder in the woman is going to be much higher if baby is born by cesarean section. Breastfeeding initiation is going to be a problem. So unless we think that there is something which we need to address to, and how we can address that in a scientific manner. It should not happen as a knee-jerk response by seeing the boss is saying this is right. Don't try to give solutions to sort out problems. Discuss with the team members who are going to make those changes, because as a leader, you have to get the work done by the frontline workers, the nurses, who will be there 24/7. And then while you do quality improvement projects, as we talk further, whatever you show as a small project which is done in a manner like a research is done, you gradually try to sustain that into the system. Sustenance is the most difficult part in quality improvement projects. And then spread from one shift to the next shift, and then to the goal, and then you make culture. Quality improvement is making a culture for the things which you think you have set it right, so that each one in that particular unit follows the same SOP and protocol which has to be done for patient care in the unit. Here comes the importance of teamwork. And to me, team is not only the faculty or the consultant and the nurses and the doctors. The family is an equal partner to this team. And even the class 4 employee who may be responsible for spreading infection in the NICU. but by not cleaning and not making hygiene proper. And how do you do that? Do we talk to our class 4 employee and the nurses by name so that they can get connected to us? Do we know their names? Who all are there and what we want to get it done from those people? And if that we can't do, we will not be able to make a good team. As a leader, we will not be able to do a good work. And the problem which you want to address has to be looked into very minute detail by a root cause analysis, which is scientific. It is based on doing fishbone analysis, which many of you may have heard, or asking 5 whys question, why this problem is occurring, and trying to map the process flow. How did this problem occur, from what time, you track it down, and then find out where the problem is occurring most by using principle of Pareto, 80-20 rule. And then you fix it, one by one, by doing small plant do study X cycle, which are called the PDSA cycle. So there is a scientific way of sorting out the problems which we want to do. And to me, quality improvement has a very strong power for improving outcomes in the baby. For VLBW babies below 28 weeks, below 1 kg, majority of the healthcare professionals will think it is inevitable that babies are going to have retinopathy or prematurity. They will say babies are going to have nosocomial infections. It is inevitable. We can't escape. But that is not true always. You can prevent this in large number of babies. In few, you will not be able to do it. But if we are able to prevent a large number, let's try to fix that problem if our rates of these problems are high. And for ROP, I would say, the theory of change will say there are 5 big pillars which cause ROP in premature baby. Prematurity is the big one, but giving oxygen therapy to the baby, giving blood transfusion to the baby, baby is getting infected, and baby is not getting mother's milk, and not doing developmental supportive care to the babies. 5 big pillars. And if we are not able to address these pillars and tease out where the problem is, our ROP will keep on happening in the unit. And for nosocomial infection, lot of neonatologists and perinatologists with lot of networks have published that you can bring down your CLABSI rate, catheter-related bloodstream infections, by doing bundle approach. These bundle approach are safe, effective care which is given in the form of bundles to the baby. And then people are able to reduce that in the networks. And you know, the outcome, which is nosocomial infection, is related to 2 things. The first is the structure. Structure is the system where the babies are getting managed. And the second is the processes. Processes is what healthcare provider does. And a Donovadian model, who is a physician, he is the first person who said it is the structure, processes which determine the outcome. And he learned this from the godfathers who started quality improvement in the Toyota industry, Deming and his bosses. They were inventors. And people have taken this forward. And in the one network, which is Vermont Oxford Network, lot of units, I know Vineet must be there as a part and parcel. They look at the data of various units and guide the people how this has to be fixed at a particular problem. There is a visit which happens by the people who see what the process of care can be improved upon. They dig out all the best evidence which can be applied in a particular unit for improving the outcome. And to me, while I visit different places, I have taught ventilation for thousands of people with my younger colleagues, Murki, Ashish, Naveen. To me, it looks we are doing something wrong to our babies who are small. If we do wrong processes for management, our outcomes are going to be bad. Why in India, bronchopulmonary dysplasia, chronic lung disease rate for 28 weaker and less, who are below 900 gram, is 40 to 50%. Why? This cannot be explained only on the basis of biology of American white kids. There are Negroes also there, but they don't have such a high BPD rates, which is like 14%, 15% there. Why we are having this 3 times? That means the process of care, we start from the delivery room and the good antenatal intrapartum care and the good first golden hour care and then doing gentler ventilation. We are missing something somewhere. This cannot be explained on the basis of biology of the babies, that our babies are 4 times more having bronchopulmonary dysplasia. We don't see ROP occurring in majority of the centers in the Western countries. It is only the very smallest kids who develop that. And read next month whole issue on retinopathy of prematurity of Indian pediatrics, experience of various centers, how they have done. And we have published in the last 20 years just doing good monitoring, good management of the baby, gentler care has reduced our ROP rates drastically low. We don't do lasers majority of the time for our intramural babies. Unless the baby is too small or too stormy post, then only they require laser. So please look at the whole issue of Indian pediatrics, which is on retinopathy of prematurity, covers what has happened in this country in the last 15-20 years. Quality improvement is not a new science, nor is this new to neonatal perinatal practice, as I mentioned. Vermont Oxford Network, CPQC Network. The first one is run by Harvard, the second one is run by Jeff Gold from Stanford, and then you have a lot of other networks of quality improvement in Europe, Australia, New Zealand. They are already there in place. This is what is needed for now India, where large number of units are churning out babies in which most of the time we are not sure of their neuromotor outcomes and neuromotor disability rates. In addition, there will be always a scope of improvement for fixing small morbidities in majority of the units which are mushrooming in the country and giving direction to younger generation what they need to do in next another 15 years or 20 years of the newborn career in which they are embarking upon. And to tell you the truth, the maximum dividends of quality improvement are going to happen in low middle income group countries or a country like India and China. And the reason for that, I say, is that at most places in India, we don't have even good evidence-based basic practices which are implemented. Majority of the healthcare systems are poorly managed systems, poor efficiency, poor utilization of resources. So these are not cost-effective care which is happening. There is too much of duplication, redundancy in the health system which we face all around us in India. In the last 2 decades in India, majority of healthcare providers, including me, were just focusing on doing education, training of people. But that education, training, and even moving skills to people will not translate into best practices so that the outcomes are going to be wonderful. There is going to be always something which will be done in a less perfect manner while they provide patient care, and that will determine the outcome in the patient. And this gap which happens in education translation, what is they are supposed to do and how they do it, will determine what has led to the outcome. If you try to improve and make it perfect, you will be able to reduce and get better outcomes for the baby. And this is what quality improvement teaches you. You all know this. Ask your heart, ask yourself, how many times it is happening that our babies are, normal babies are, getting early initiation of breastfeeding? How many of our babies who are term babies without any problem are on exclusive breastfeeding rates at 6 months of age? I don't have to give you a review and science and the basis and the evidence that breastfeeding is the best immunization for the baby, even for a small baby. But if you ask people why it is not occurring, most of the people withdraw and they say, oh, we have too much of work, overloaded. But if you try to map what the nurses and doctors are doing during that period of shift in the duty, you will come to know there are so much opportunities for doing all this, but still we get away from not doing it. And the reason for that is simple. It is the attitude, the behavior, which is the hardest to fix. And this can only happen if people come forward themselves making a team and there is a leader who guides them that this is the right way of doing the things. And this is what quality improvement teaches us. Going around in the country, I have seen every baby born by cesarean gets in many private nursing homes antibiotics also. And I learned from Murki, he saw in Andhra and Telangana, babies under phototherapy are treated by antibiotics also in addition. And you go to a community hospital, you will come to know that oxytocin is not being given to the mother within 1 minute of following delivery. There may be reason with the supply, logistics, or maybe the processes of giving this are not planned in a better way, but certainly this can be looked into. Because it causes maternal mortality due to postpartum hemorrhage, the single most important cause which kills the mother. And look at, while a baby comes to an emergency, how much time it takes for that baby, suppose the baby is in shock, to get his first shot and bolus injection. The international guidelines say within 10 minutes he should get, 10-11 minutes he should get. The more you delay, you know what will happen. So if that is a problem in your setup, you will have to measure it in at least 10 babies what is happening. Look at that data and then plan out what the reason is and do the root cause and try to make sure from that 24 minutes you will bring it to 10 minutes over a period of 6 weeks over next 10 babies. Do it small, learn it. Learning of doing that will educate you whether you are able to fix those processes well or not. If your frontline workers with the change of processes are not able to fix it, it is very hard that you will be able to sustain this in long run. Remember this for quality improvement. So quality improvement applies to healthcare in each and every sphere. You come to know which processes you need to focus. It makes you a better clinician. You learn from finding out where medication errors occur, blood transfusion mismatch occurs. It adds to value to clinical acumen. To a surgeon who does surgery, if his patients are not infected following surgery and the hospital duration is reduced, hospital saves the money, patient is happy. It saves the resources. But if someone is not doing hand hygiene, not taking precaution, and there is post-operative infection, it is waste of resources in that hospital. And for me, I teach this to my resident. Each time you touch your baby or do any procedure in that particular newborn, always think what you are doing on the baby, will this lead to any bad outcome? This will itself change your mind so that you will be able to do the processes in the right manner. And as I said, doing knowledge, transmission and moving to people, making people skillful, even making people competent by teaching on simulator, there will be gaps in care which will happen, which have to be filled by this quality improvement technique. At this point, I would like to elucidate to you the definition of first quality of care, which is given by Institute of Medicine way back in 2001. It has 6 pillars. It is patient-centric. It says patient must get the effective care. That means best evidence-based practice care. The care must be safe for the patient. There should be no harm. Patient must get timely care. That means he must meet the nurse or the doctor at the right time so that he gets this effective care. In addition, it mentions there has to be efficiency of care. Efficiency in terms of saving time, saving resources, and providing the best care for the patient. And the last thing is equity of care. The rich and poor must get the same care. This definition in 2014 has been little bit modified by World Health Organization. And what they say is, they included in this patient satisfaction, patient's respect for care, patient's dignity of care. So it is respectful care, dignity of care, especially for mother and newborn in the delivery room, and then patient satisfaction. How does the community and the patient and the families feel after visiting the hospital? You know, if they are not happy, they will start coming to the hospitals after some time. Then what will happen? We would be sitting there, but no patients. They will move to another facility where better care is being given to the patient. So the quality of care is a big umbrella. It has 2 big pieces, which I said. One is the structure, which is called as quality assurance. Quality assurance deals with the inputs. This is the manpower, equipment, supply, the SOPs, the guidelines which have to be done, and the checklists which have to be done. The second piece of quality of care is quality improvement. This is to be done by a healthcare provider. It needs not much resources, but it always needs support from the quality assurance side. You need a system also to work many times while you want to do quality improvement. Ideally, there are a lot of things which we can do without asking for money. Like, who has stopped us from doing delayed cord clamping? Does it need money? Someone said it increases the iron score, makes the baby stable better. Does it need money? Who has stopped us from doing skin to skin care to the baby for preventing hypothermia in the baby and early initiation of breastfeeding? But as a neonatologist or pediatrician, you can't do it alone. You will have to involve all the stakeholders, the obstetrician, the labor room nurse, your team, your doctors, and the class 4 people who are there, and the families. If there is a grandmother who is so assertive that she will give something else, you need to take the community also on board. So doing quality improvement is within the same resources, not asking money, and trying to see and get interested in trying to sort out small problems which exist in your system. I can never imagine that anyone will tell me that there are no problems in his health facility. If someone says that, the biggest problem lies in that place where healthcare providers say we don't have any problem, our system is perfect system. And unless we measure what we are doing, measurement is the key on which improvement will tell you that whatever you do, you are improving over time or not. So unless we measure what we are doing, you will not know what led to improvement, what change you will do and what led to the improvement. Remember this dictum. So this I already said. One piece is quality assurance, and what has happened is in the last 3 decades in neonatology, whole effort has gone into quality assurance. People do only accreditation. They come with a checklist. You have this, your facility is accredited. Sorry sir, Dr. Naran had the vision of making that. But I am not saying it is not important. It is the main thing on which quality improvement will occur. You need a system to work on. But there are a lot of things we can do as quality improvement, which is a continuous process. It is not only doing one project and then forgetting about. It has to become culture. People and the team keeps on looking at one problem, next problem, set it right, make it a culture, next one. At AIMS, in Department of Pediatrics, we are going to launch 10 quality improvement projects for making sure that antibiotic stewardship program can be made a culture in all the 4 units of pediatrics department. This cannot happen by my saying it. This cannot happen by saying of the director or the administration who are on totally board and DMS. You will have to influence the head of the departments and the people who control the frontline worker. And this influence also has to be one-to-one talk and convincing people that this is the way out, we can do all this, let's work together. And then, if they get converted, they will tell all the faculty members and all the resident doctors and nurses that it has to be done that way. So, doing quality improvement is not only that people keep on slogging and working there in the unit and do quality improvement. They must get reward, recognition. It must be brought to the notice of the higher ups, the MS, the CNO and the other people, and even up there to the director. Then only it becomes a culture and people start willing to do quality improvement work. Now you will say, Dr. Deorari, आ गए हैं यहाँ पढ़ाने के लिए, पता नहीं क्या बोले जा रहे हैं। ऐसा है, जितने आप लोग बैठे ना यहाँ 100, मेरे को 100% पता है, जो मैं आज बात कर रहा हूँ, खाली 10 या 15% लोग ही उसको पकड़ पाएंगे और जाके अपनी अपनी जगह में करेंगे। और मेरी एक्सपेक्टेशन भी यही है कि अगर मैं 10 लोगों को भी 100 में से कन्वर्ट कर दूं फॉर डूइंग ऑल दिस एंड दे स्टार्ट थिंकिंग ऑन दिस वे, माय जॉब इज डन, दैट दे आर थिंकिंग अबाउट क्वालिटी इंप्रूवमेंट. So Quality improvement helps to bridge the gap between what we know and what patients receive, because that determines the outcome in the patient, and this is at the point of care. And the gaps in quality can happen at the input level, which I said, quality assurance, accreditation, or it can be by guidelines and protocols, training materials and other things which have to be done. And the process, change in process, this is a continuous thing which has to happen in the unit. That is going to determine the outcome. And that for doing this, many times you need the leadership on board. And I'm so pleased to tell you now this, that at IXth, we have convinced a lot of departments to start doing quality improvement as their dissertation and thesis. This has come from the mouth of the director to all the HODs. So people are not doing research work, which is a duplication research, which I say, and most of the time the research work does not give you dividend and you are not able to see what you are doing. The fellow does the thesis, लिखता है, सब कुछ लिखता है, उसके बाद खत्म हो जाता है. Quality improvement में you are able to see with your own eyes what is happening, and then it is your job to make it that sustained in the system. It is like doing an implementation science. Implementation science is totally different as compared to what a randomized controlled trial or meta-analysis will show you. A typical example is the huge big RCTs and Cochrane shows antenatal corticosteroids do wonders in premature babies below 34 weeks of gestation rate. Read the Lancet November 2014 paper, that while it was done in 6 countries, antenatal corticosteroid use, it increased the rates of purpural sepsis in the mother by 45% and increased the mortality in newborn and stillbirth by nearly 20%. That means there were some flaws in selection of cases, that part is true. But it means that a study which is huge, big, done in tertiary care hospital, while you try to apply that in the community, your context is totally different. Indian context, hygiene of the woman, all those things, and we don't have a setup to provide care to these babies who are going to get delivered there in the health facility. So your mortality rates also are going to be high. So our context is totally different. So the implementation science is totally different as compared to what the research or RCT will show you. And here I put what is the advantage of doing quality improvement over research. As I said, quality improvement intent is to improve the current practice. You get instantaneous result within days. It is contextual. Ownership is by the team. Research is you make a protocol, you stick to the protocol. You can't change in between. In QI, you can change your PDSA, learning from that. And then research may be generalizable. I gave you an example where it failed. It is always a high cost investment doing research. It takes time, 1 year, 2 years, and then most of the time the thesis is written by the faculty who is the guide or co-guide, who are guide and co-guide most of the time. And QI gives you the equal dividends. You can make international presentations, go to meetings, posters. There are few journals which are dedicated to, BMJ is dedicated to quality improvement topics. You publish it there. There are international journals which give preference to quality improvement work, but they should be done with a rigor with at least 2 or 3 PDSA cycles. And there is a way how that paper has to be written. And there are guidelines for, square guidelines for writing a quality improvement paper, if you want to submit to a journal. So as I said, people are moving away from research to quality improvement, and this is going to be the next 1.5 or 2 decades. Read about the SDG goal of 2030. In SDG goals, there are 2 things which say about quality care and quality improvement for patient. And whole of the global community doesn't want to now invest on only doing education, training and workshops of people. They are saying, if it is not leading to a change and improvement in the the places from where these people are coming, what work is that training and education, and people who move knowledge to people rather than moving people using IT technology also have also realized there is no point unless people are willing to learn and improve and apply the things will not improve backside. Many of us who are senior profs have done quality improvement intuitively in the places where we have worked. And to me, that is an informal approach to quality improvement. You must have seen, in a round you find a baby who is hypothermic. You try to fix the problem, what the reason is. You take action at that point of time. It lasts for a few days. Then another 2 babies come. Because we did not address this big problem of hypothermia occurring in postnatal ward in a scientific manner, using a tool and creating a team. It is not only responsibility of consultant to pick it, but it is a responsibility of even the mothers to pick those babies early by doing education, or the nurses doing it. So if it is an approach which is a scientific approach, you can create a system for it. So QI is systematic, data-guided, knowledge-informed, innovative, employs formal, explicit methodology. It is a continuous process, and often it needs a system change. On the other hand, informal is episodic. It doesn't last. It is experiential, anecdotal. This cannot be shared in any forum. I would not talk about Vermont Oxford database, but just try to share with you what did we learn, why we did QI uptake in India, in the CRO region in many countries, and at AIMS. At AIMS, it is a topmost institutional commitment by our director, the MS, the DDA, and all the head of the departments. Majority of them, they join, they want to do QI. And what we tell them is, provide us faculty members who are ready to implement and create, because I can't go, other people can't go. So we have people from obstetrics, trauma, pediatrics, eye care, surgery, anesthesia department, emergency department, young faculty members who create team and start doing all this. And as I said, you need this commitment from up there. In addition, you need a local leader and a champion in that particular department. He also needs to be in good books of the head of the departments who will let them do quality improvement work. Because quality improvement work is an additional little bit responsibility on you. But you don't have to ask for resources and time for it. Time is plenty. Young people, save your time on WhatsApp. You save 3 hours out of your 10-hour duty. I'm telling you the truth. And this saving of time will only occur if WhatsApp starts charging huge amount of money for the data which people use on WhatsApp. Then only the Indians will learn. I have not seen in Western countries people using mobile phone in the units. Here you find, you go to a place, resident doctors and often the nurses will be using the movie and WhatsApp all the time. And then still they will keep on cribbing, we don't have time. How can we do quality improvement work? This is our problem. How do you make that change? So you need leaders, you need teams, and the best part at AIMS is we have started doing this in undergraduate medical education. We have started doing sessions for the MD resident and senior resident by doing workshops for them, 5-hour sensitization workshop for QI. For the nurses, 5-hour workshop for sensitization for QI. And from next year, January, all new recruit will be exposed to this every 6 months whenever they get into our system at AIMS. In addition to quality improvement work, which keeps on going. So we have thesis, dissertation which are going to in. We have sharing opportunities, we do workshops, we give recognition, reward for people, and people, director is so much into it that even in the Asia reports, there is a column which is made now. What quality improvement work you have done in the last 1 year. He says, I don't want to read how many workshops in CME Dr. Deorari attended and did deliver lecture here and there. I want to see what quality improvement work he has done. World is moving towards that. World is getting to looking at stillbirth and audits for quality improvement. And the best part is, we have created a very simple tool, which is a 4-step tool for quality improvement at WHOCC AIMS. And we use this tool to teach people. 4-step basic tool. And we took the help of USA assist people and IHI people to do it, and then PDSA cycles. We are there on the website, as I said. We are there on the social media, on Twitter, Facebook. We have 6 Facebook pages with quality improvement teams in different countries and India and at AIMS. And for doing all this, not a work of individuals, multiple partners, multiple people involved into it, and who believe, first is believe in that you want to improve the care for your patients. Thank you so much.
Thank you, Dr. Deorari, for an excellent presentation. So, any question from audience?
I would just add one line. There are 6-7 audio-visual podcasts which are there on our website, which tell you and give you idea of small QI projects which are done at AIMS, including neonatology. Yes, sir.
First of all, I must thank Dr. Deorari for bringing this important subject into the fora of this conference. Usually what happens, I think I remember about 30 years back or so, when I had a chance to work with Dr. Ghai. That time he was the head of the department in AIMS. Dr. Deorari was also there. So the neonatology was just taking work. That time it was a small room, say about 8 or something like this. Everybody has in mind that quality should improve within that small premises, and that was followed by the people who came after that. Recently, when I was going through that Lancet data that says that only 37% breastfeeding women, they continue exclusive breastfeeding. In the meantime, there was a book in 1901 written by one Ayurvedacharya, Kaumare Bhritya Chaitam. It was a book which was accidentally I got through that book, and when I did, the exclusive breastfeeding was one of the prerequisite that time, and probably it was 100%, but how it came to 37%, that was the question which we had to think about. Probably when I gave some thought on this particular thing, I thought that possibly due to a rise of these media, the propaganda programs, they led to retrograde or rather decline of the breastfeeding. Again, we are realizing the same programs to improve the rate of breastfeeding. Is it not an irony?
So, I think life moves that way. You make mistakes, you learn out of mistakes.
Please, just let me come. Why I want to say, how I pointed out this, that yes, it is important to use the modern tools, but it is also important to show the things. Show the things to be done, how it is done. Possibly the people who worked in earlier part of the development of the neonatology, they have seen the things and they believed, and possibly they brought out those things to their institutions, started working there. In the meantime, these things become topsy-turvy. Again, we are realizing it. I think that's what I wanted to point out. And thank you, Dr. Deorari, that bringing this forward.
Thank you, sir. You should look at a audiovisual podcast on how in BLBW babies in our NICU, increase in giving mother's milk has increased from baseline to that babies are getting majority of the milk. So one need to look at that audiovisual podcast, and that is not a cultural unit. www.aiimsqi.org। ये जो आपको प्रिंट आउट दिया हुआ है, बुकलेट दी हुई है, वहाँ पे स्लाइड में नीचे लिखा होगा।
Sir, what database management tools you using? Which database?
Which
database management software tool you using?
So, while we do quality improvement projects, small ones, which have to get into improving clinical practice, so you have to create run charts based on the information which you use. So there is a software which is called as EMRO 2016. It creates all your run charts and everything from the Excel which you put into it. So there is a software which is freely available which you can download. EMRO 2016.
Dr. Deorari, with respect to you, and with all the talks that you delivered on this quality improvement, I think we should not confuse. I think we should not confuse quality improvement by more and more advanced care. Quality improvement simply says that your knowledge should be transferred onto your table and onto your beneficiaries. So whatever you know in your mind, it should be transferred properly. It might be a very simple thing. Suppose a doctor working at a primary health center, his knowledge according to his infrastructure involvement, whatever he has got, he needs to give a basic care. So if he is able to teach simple hand washing to all his staff, that is a good quality care. And quality care always starts with individual going into the system. I don't agree with you that is the individuals cannot have a quality improvement. It won't last. Quality improvement means whatever you know and whatever infrastructure you have, but you translate it, and that is your quality improvement. And as far as softwares are concerned, quality improvement doesn't need a software. Data also you need to make your data, but all the data will differ according to your infrastructure and according to your work profile. Quality improvement means whatever work profile you have got and whatever infrastructure you have got, you are delivered the best. That is the quality.
So, I hope my message here was not teaching tertiary care neonatologists that quality improvement cannot be done by people who are in the nursing home or in small places. Any place wherever you work, you can think of some problems which you want to fix, and then with a team approach, you can try to get it done and make it in the sustainable manner. Individual single things will happen only while he or she is managing that patient, but it will not percolate to the other members unless it is shared, and it is a team and a shared vision of the team. Thank you so much for giving me.